Alexander Fleming, the man who, literally discovered penicillin, stood up in 1945 and delivered a warning that
should have completely changed everything.
yeah, frankly, it should have sent chills down the spine of modern medicine.
Absolutely.
He was accepting the Nobel Prize. He had just handed humanity the ultimate weapon against infectious disease. And yet, he used that moment to say, and I quote, "The time may come when penicillin can be bought by anyone in the shops."
Right.
Then there's the danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug, make them resistant.
He saw the whole thing coming.
He really did. Almost 80 years ago, he outlined a nightmare scenario with just terrifying precision.
Yeah.
And today, for you, me, and everyone listening, that nightmare isn't some dystopian novel.
No, it's our baseline.
Exactly. It is our daily operational reality. So welcome to this deep dive. We are incredibly glad you are here with us today.
Glad to be here.
Today, we're unpacking antimicrobial resistance, or AMR, the silent pandemic. We're talking about the terrifying rise of superbugs that simply no longer respond to our medical arsenal.
It is the defining public health crisis of our generation.
Yeah.
Period. Even if it doesn't always command the front page headlines it deserves.
Yeah.
To really understand the sheer scale of this, we have to synthesize a massive amount of data.
Right. We've got a lot to get through.
We do. We're pulling together insights from the World Health Organization's Global Action Plan, detailed epidemiological studies, the brand new 2025 GLIAS report.
Which is fascinating, by the way.
It is. And some truly fascinating, highly detailed business plans and personal accounts regarding innovative public health triage systems.
Specifically looking at the Prima kiosk and the Dr. Maya app.
Exactly, because the goal here isn't just to list statistics for an hour. It's to understand the biological mechanics of this crisis.
Yeah, we have to look at how we accidentally trained bacteria to defeat our very best weapons, how the COVID-19 pandemic acted as an accelerant, and the cutting-edge strategies being deployed right now to save modern medicine.
Because if we don't understand the mechanisms, we can't understand the stakes.
So true. So let's just start with the raw, uncompromising numbers. Where does the global death toll currently stand, and where is it heading?
Okay, so the numbers paint a picture of a crisis that is already fully entrenched. In 2021 alone,
Just that 1 year.
just 2021,
Yeah.
bacterial AMR directly caused 1.14 million deaths globally.
Direct cause.
Direct cause, but it was associated with 4.7 million deaths.
Okay, wait. Explain that distinction for everyone.
Right, so that means in those 4.7 million cases, the patient had a primary condition, maybe cancer, maybe severe trauma,
Right.
but the resistant infection played a significant, often decisive role in them not surviving.
Got it.
But the forecast is what keeps epidemiologists awake at night. If we maintain the current trajectory, the models project 39 million direct deaths by 2050.
39 million.
Yeah. We are looking at a potential drop in global life expectancy by 1.8 years within a decade.
A drop in global life expectancy. I mean, after a century of pushing that number relentlessly upward, we're moving backward.
Exactly. And the economic fallout perfectly mirrors the biological one. The projected loss to the global economy could reach a staggering $100 trillion by 2050.
Trillion with a T.
With a T. You cannot run a globalized, highly interconnected economy when routine bacterial infections keep large swaths of your workforce chronically ill.
Or worse.
Or worse.
And when we drill down into the specific threats, especially within our hospitals, we encounter a group of pathogens with a genuinely ominous yet fitting acronym.
The escape pathogens.
Right, the escape pathogens, ESKAPE. This stands for Enterococcus faecium, Staphylococcus aureus.
Which most people know as staph.
Yeah, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter species. These are the bugs that absolutely rule hospital intensive care units. They dominate the ICU precisely because they have essentially figured out how to escape our antimicrobial safety nets.
Hence the name.
Hence the name. And this isn't magic, it's molecular engineering. Bacteria are arguably the most successful organisms on the planet because of their adaptability.
Right.
When we look at the biological battlefield, we can categorize their defenses into 7 distinct mechanisms of resistance.
This is where the biology gets both fascinating and deeply alarming.
It really does.
I like to think of these bacteria as a besieged castle that is rapidly evolving while under attack.
That's a great analogy.
Right, because we fire our chemical weapons at them, and they don't just sit there. They respond. So let's walk through these 7 mechanisms, because understanding them is crucial to understanding why our drugs are failing. First up, you have enzymatic degradation.
Right. Think of the antibiotic as a key designed to fit into a specific lock on the bacterial cell wall to tear it open.
Okay.
Enzymatic degradation is the bacteria producing an enzyme.
Like a biological scissor. Essentially, yes. A biological scissor that floats around outside the cell and physically chops the key into pieces before it ever reaches the lock.
Wow.
Beta-lactamases are the classic example here. They literally break the structural ring of penicillin-type drugs.
So the weapon is destroyed before it even hits the target.
Exactly.
Then we have the second mechanism, which is enzymatic modification.
This one is slightly more insidious. Instead of destroying the drug, the bacteria's enzymes attach a bulky chemical group onto the antibiotic molecule.
Okay, so what does that do?
It's like putting a boot on a car. The drug is still intact, but its shape has been altered so fundamentally that it can no longer bind to its target inside the bacteria. It's completely neutralized.
Okay, so that's dealing with the drug outside or right at the surface. The third mechanism is limiting entry. Going back to the castle analogy, this is just building thicker walls and sealing the gates.
Precisely. Gram-negative bacteria have an outer membrane with these tiny channels called porins. Right. Antibiotics usually slip through these porins to get inside. When the bacteria sense an antibiotic threat, they can genetically mutate to either shrink the size of those porins or reduce the number of them entirely.
They just shut the door.
They literally close the gates, starving themselves of certain nutrients just to ensure the drug cannot get inside.
That is wild. And if the drug does somehow manage to breach the walls, we get to the fourth mechanism, which absolutely blows my mind. Efflux pumps.
The mechanical efficiency of an efflux pump is terrifying.
Yeah.
It's a protein channel embedded in the cell membrane. It acts as a biological bouncer.
Okay.
When an antibiotic molecule successfully gets inside the cell, intending to disrupt its machinery, the efflux pump recognizes the foreign chemical, grabs it, and actively pumps it right back out of the cell.
And it does this faster than the drug can accumulate to lethal levels.
Yes.
Wait, mechanically, how does it know? Is it identifying the specific chemical structure of the drug, or is it just sweeping up anything that isn't supposed to be there?
That is the core of the problem. Some of these pumps are highly specific, evolved to eject one type of toxin, but others are multi-drug efflux pumps.
Oh, no.
Yeah, they act like broad-spectrum bouncers. They recognize general characteristics of foreign molecules and sweep them all out.
Wow.
This means a single genetic mutation, giving a bacteria an upregulated multi-drug efflux pump, can suddenly make it resistant to 3 or 4 entirely different classes of antibiotics at once.
That's horrifying. They just throw our best weapons right back over the wall. Which brings us to number 5, modifications to drug targets.
If the antibiotic does get in and avoids the efflux pump, it usually seeks out a specific target, like a ribosome, which the bacteria uses to make proteins.
Right.
The bacteria can mutate the shape of its own ribosome just enough so that the antibiotic can no longer latch onto it. But the ribosome still functions perfectly well for the bacteria.
It's like changing the locks on the doors inside the castle.
Exactly.
Mechanism 6 is alteration of metabolic pathways.
Some antibiotics work by blocking a crucial metabolic road. For example, sulfa drugs block the pathway bacteria use to synthesize folic acid, which they need to survive. The bacteria's response. They simply evolve to bypass that roadblock entirely. They develop an alternative biochemical pathway to synthesize folic acid, rendering the drug completely irrelevant.
It's like closing down the main highway so the bacteria just build a detour through the woods.
That's exactly it.
And finally, the 7th mechanism, which we hear about a lot in hospital settings, biofilm formation.
Biofilms are the ultimate defensive fortification. Instead of floating around individually, communities of bacteria hunker down together on a surface.
Often a medical device, like a catheter or an implant, right?
It's very common there. And they secrete a thick, slimy polymeric matrix over themselves. It acts like an impenetrable moat.
Gross, but effective.
Very effective. Antibiotics simply cannot penetrate deeply into the biofilm. Furthermore, the bacteria deep inside the biofilm slow down their metabolism.
Because antibiotics usually target active cells.
Exactly. Since many antibiotics only target actively dividing cells, these dormant bacteria survive the chemical bombardment and then wake up to repopulate the infection once the antibiotic course is finished.
When you lay out all 7 mechanisms like that, degrading the drug, modifying it, blocking entry, pumping it out, changing the internal targets, bypassing metabolic routes, and hiding in biofilms.
It's a lot.
It is. You realize we aren't just fighting a single biological quirk. We are fighting billions of years of evolutionary survival programming.
And this brings us to the stark reality of what modern medicine looks like if these mechanisms become universal.
Yeah.
Without antibiotics, routine procedures become existential gambles. We aren't just talking about surviving the plague. We are talking about cesarean sections, hip replacements, organ transplants, chemotherapy.
Because all of those either suppress the immune system or open the body up.
Exactly. They open the sterile interior of the body to the outside environment. Without a reliable, guaranteed safety net of antibiotics to prevent or treat the inevitable infections, these standard medical miracles become incredibly, exponentially dangerous.
To put some hard numbers to this evolutionary arms race, we can look at the 2025 GLAS report.
The Global Antimicrobial Resistance and Use Surveillance System.
Right, and the data is deeply alarming. They found 42% resistance in E. coli to third-generation cephalosporins.
42%.
That's almost half. And these are vital go-to drugs for incredibly common issues like severe urinary tract infections.
And for MRSA, methicillin-resistant Staphylococcus aureus in bloodstream infections, the global resistance level is tracking over 27%.
So you have more than a 1 in 4 chance that a staph infection in your blood will essentially laugh at the standard first-line treatment.
And a bloodstream infection isn't something you can wait around on. Every hour that you receive the wrong antibiotic, your mortality risk skyrockets.
Which naturally begs the question, how did we get here? How did we take Fleming's miracle and drive it into the ground in less than a century? We know human behavior drove this hyperevolution, but let's look at the mechanics of that overuse.
The primary driver is the application of massive, unrelenting evolutionary pressure. And we have to start by acknowledging that human medicine is only half the problem.
Right, the agri-food sector.
Antimicrobial use in farming, livestock, aquaculture, it's staggering.
Yeah.
The projections suggest usage in this sector will reach 142,481 tons by 2040.
Tons! That is an unbelievable amount of chemical.
We are dumping these chemicals into our food chain and our environment at an industrial scale. We use them not just to treat sick animals, but as growth promoters and preventative measures in crowded, unsanitary factory farms.
Which just applies a continuous low-dose pressure on environmental bacteria to adapt or die.
And the ones that survive are, by definition, the superbugs.
But looking at the human side, the issue of self-medication is an absolute crisis, particularly in low- and middle-income countries, or LMICs. Let's talk about the data out of India. There's a specific statistic from the state of Punjab that is hard to wrap your head around. 73% of the population resorted to treating their minor health issues and even chronic illnesses through self-medication with antimicrobials.
That number requires deep socioeconomic context, though. We cannot just point fingers at a population and accuse them of acting recklessly.
No, of course not.
People in these regions are not self-medicating out of a desire to ruin global health. They do it out of raw necessity. In many LMICs, there is a profound lack of access to physicians.
And even when clinics exist, the costs are prohibitive.
Exactly. The high costs of medical consultations, diagnostic tests, and the sheer loss of daily wages required to wait in a crowded clinic all day make formal healthcare inaccessible for a day laborer.
Right. If you make 500 rupees a day, you can't afford to lose a day's pay and spend another 500 on a doctor just to be told you have a cold.
Exactly. But you can walk into an unregulated local pharmacy and buy a strip of potent antibiotics over the counter for a fraction of that cost.
Because the supply chain is heavily commercialized and underregulated.
So when you are sick and the social safety net is non-existent, you reach for the cheapest, most immediate perceived fix.
And the tragedy here is the fundamental diagnostic blind spot.
Mm-hmm.
We all know antibiotics are useless against viruses. They do not kill viruses. But patients, and frankly overworked doctors, are utilizing them for viral illnesses constantly.
Huge issue.
I want to highlight the malaria paradox because it perfectly illustrates the systemic failure.
The malaria paradox is a textbook example of clinical desperation. In regions where malaria is endemic, but perhaps decreasing due to mitigation efforts, a patient comes into a rural clinic with a high fever.
Okay.
The doctor does a rapid diagnostic test for malaria. It comes back negative.
Right.
Well, the doctor has a patient with a dangerous fever, but they lack the rapid, accurate bacterial panels or biochips required to determine exactly what the pathogen is. They are flying completely blind.
And without a lab to culture the blood, which takes days anyway, what do?
They prescribe a broad-spectrum antibiotic because the immediate risk of the patient dying from an undiagnosed bacterial sepsis vastly outweighs the abstract, long-term threat of global antimicrobial resistance.
They have to treat the patient sitting right in front of them.
Exactly. The diagnostic gap forces them into terrible stewardship.
And this diagnostic gap is mirrored by a massive public knowledge gap. There was an incredible survey of over 55,000 people across Europe, Asia, and North America.
I remember this one.
Yes, 70% of the public had heard the term antibiotic resistance. But 88% of those people fundamentally misunderstood what it meant.
Which is wild.
They thought antibiotic resistance meant that the human body was physically changing to become resistant to the drugs.
It is a critical failure in public health communication.
Yeah.
People believe that if they take too much penicillin, their personal metabolism will just become immune to it, much like building up a tolerance to caffeine.
Right. They think it's about them, not the bug.
They do not understand the evolutionary biology at play. They don't realize that they are acting as a bioreactor, hosting a newly evolved drug-immune superpathogen that they can then cough onto their children or leave on a door handle.
And the immediate danger of this self-medication isn't just creating the superbugs of tomorrow. It's the direct physical harm to the patient today. Let's look at a drug like ciprofloxacin.
A powerful fluoroquinolone antibiotic.
Right. People will buy it over the counter for a viral cough. They get absolutely zero benefit for their viral symptoms, but by ingesting it, they open themselves up to severe documented side effects.
Very severe.
We are talking about tendon rupture, aortic dissection. You could literally tear an Achilles tendon or suffer catastrophic vascular damage taking a heavy-duty antibiotic that isn't even fighting your illness.
It's the definition of all risk and no reward. And this fragile ecosystem, driven by overuse, lack of diagnostics, and economic disparity, was already pushed to the absolute brink by 2019.
Which raises the inevitable tragic question.
What happens to a global medical system teetering on the edge of an antimicrobial crisis when a novel, terrifying virus shuts down the entire world?
Which brings us to the COVID-19 catalyst. We had a global viral pandemic. Logically, since COVID is a virus, you would assume antibiotics wouldn't be a major factor in the clinical response.
You would assume that, yes.
But COVID-19 ended up acting like absolute gasoline on the superbug fire. The central paradox of the early pandemic was that a virus triggered the most massive global spike in antibiotic use we have seen in decades.
The initial datasets, particularly from the early epicenters, are staggering. In Wuhan, the epidemiological data showed that 95% of hospitalized COVID-19 patients received antibiotics.
95%.
Yet, when subsequent rigorous studies were conducted on those cohorts, they found that very few of those patients actually had secondary bacterial co-infections.
So they didn't even need them.
The vast, overwhelming majority of those antibiotic prescriptions were biologically unnecessary.
We really need to unpack the psychology of the frontline healthcare workers during those first few months. Why were highly trained specialists throwing broad-spectrum antibiotics at a respiratory virus?
You have to mentally place yourselves in the reality of an ICU in early 2020. Frontline workers were overwhelmed, physically exhausted, and facing a terrifying unknown pathogen with a rapidly escalating mortality rate.
It was chaos.
Absolute chaos.
Yeah.
They didn't have vaccines. They didn't have targeted antivirals. Doctors used antibiotics as a psychological and clinical shield.
Shield?
Yes, they were prescribing 3 or 4 powerful antibiotics concurrently to critical patients while waiting for lab results, simply trying to plug any possible gaps in infection control.
It was pure desperation.
Completely. As infectious disease experts noted at the time, if a patient on a ventilator seemed to be stabilizing even slightly, doctors were utterly terrified to de-escalate the antibiotic regimen.
Don't mess with what might be working.
Exactly. The clinical focus narrowed entirely to the immediate survival of the human being in the bed. The long-term ecological price of antibiotic resistance was a luxury problem pushed down the road.
And it wasn't just the sheer volume of antibiotics. It was the cascade effect of the other life-saving treatments. The devastating impact of steroid use cannot be overstated here. Let's talk about dexamethasone.
A vital drug during the pandemic.
It became a frontline miracle drug for severe COVID because it tamps down the body's immune system to stop the exaggerated inflammatory response.
The cytokine storm.
Right, the storm that was destroying patients' lungs.
But biology always demands a trade-off. By chemically suppressing the immune system to save the lungs from inflammation, the steroids left the door wide open for opportunistic secondary infections.
Ah, I see.
Fungal spores and environmental bacteria that a healthy immune system would normally crush without a second thought suddenly found a completely undefended host.
And the most horrific manifestation of this was the outbreak in India during their catastrophic second COVID wave. We saw over 4,000 cases of mucormycosis.
The black fungus.
Right. It's a highly aggressive, deeply destructive fungal infection. It wasn't just bad luck that it spiked.
Yeah?
It was a direct biological consequence of using high-dose steroids on diabetic patients to fight COVID, which created the exact immunosuppressed, high blood sugar environment the fungus needs to thrive.
Furthermore, the physical environment of the overwhelmed ICU itself became a massive vector for the escape pathogens. Epidemiologists track what they call the drip and cannula risk.
Okay, what is that?
During the peak of the pandemic, hospitals observed a 2- to 3-fold increase in bloodstream infections that were directly linked to invasive devices, central lines, urinary catheters, intravenous drips.
Because the patients were in the ICU for so long.
Yes. Because COVID patients were surviving longer in the ICU, kept in prone positions on ventilators with multiple plastic lines extending into their blood vessels, the physical opportunities for hospital-acquired superbugs to bypass the skin and enter the bloodstream multiplied exponentially.
And then you have the hygiene paradox. During COVID, society's response was to sanitize absolutely everything. We deployed massive amounts of biocides, heavy industrial disinfectants, and alcohol sanitizers.
We sprayed down streets, hospital corridors, everything.
But from an evolutionary standpoint, what does that do?
It creates a toxic environment that only the absolute strongest can survive. Extensive, indiscriminate use of these disinfectants applied extreme selective pressure on the microbes living in the hospital environment.
It's that same evolutionary pressure again.
Exactly. We essentially eradicated all the weak, susceptible bacteria, leaving behind only the hardened, mutated strains. We cleared the ecological niche for the superbugs to dominate.
But the most tragic irony of the pandemic might be how our protective measures backfired psychologically. We saw unprecedented levels of PPE fatigue.
The psychology of personal protective equipment is fascinating here. Health workers were wrapped in multiple layers of gloves, fluid-resistant gowns, face shields, and N95 masks.
Like armor.
Like armor. Because the gloves made the staff feel personally, physically protected from the virus, there was a subconscious psychological shift. They felt a barrier existed.
Right, I'm safe, so I'm good.
Exactly. This negated the perceived urgency to wash their hands as frequently or as thoroughly between patient interactions. The gloves themselves became contaminated.
The armor meant to save the doctor became the vehicle for the bacteria. They became human vectors, moving Acinetobacter, or MRSA, from one vulnerable immunosuppressed patient to the next.
Heartbreaking.
It is. Now, it is crucial to note that this wasn't a universal failure. There was wild variance in how different medical systems handled the pressure. Contrast the Wuhan data, where 95% received antibiotics, with data from a specific, highly regulated cohort in New York.
Right, the New York study.
Out of 393 severe COVID-19 cases studied in that specific system, only 5.6% actually developed bacteremia. And crucially, none, 0%, received unnecessary antibiotics in that group.
Which is incredible.
It showcases that even in a crisis, rigorous antimicrobial stewardship is possible.
It proves that the protocols work, provided the system has the resources and the discipline to maintain them. Because while a hospital is clearly a dangerous place during a pandemic, the public health apparatus actually has incredibly meticulous step-by-step methodologies for tracking these threats when they break out into the wider community.
And that takes us out of the ICU and into the world of the epidemic detectives. Tracking an outbreak is not guesswork. It is a rigorous, almost militaristic scientific process. The World Health Organization outlines a strict 10-step outbreak investigation protocol.
It's a fascinating framework. Step 1 is simply preparing for fieldwork, having the logistics ready.
Makes sense.
Step 2 is establishing the existence of an outbreak. Is this a true cluster or just a statistical anomaly? Step 3 is verifying the diagnosis, confirming the exact biological agent in a lab.
Okay, so figure out what it is.
Right. Step 4, crucially, is defining and identifying cases. Who exactly is sick and what are their specific symptoms? Step 5 involves performing descriptive epidemiology, mapping the data by time, place, and person. Who, where, and when.
And from there, Step 6 is developing hypotheses based on that map. Step 7 is evaluating those hypotheses with analytical studies. Step 8 is refining the hypotheses and executing additional studies.
Testing the theory.
Testing the theory, yeah. Step 9 is implementing control and prevention measures. And finally, Step 10 is communicating the findings to the public and the broader medical community.
It's a flawless, logical loop. But the reality on the ground is that systemic shortcomings frequently allow outbreaks to outpace the detectives.
Always a catch.
Always. We are talking about hospitals lacking dedicated negative pressure isolation wards. We are talking about poor wash infrastructure, water, sanitation, and hygiene in developing nations. And we're talking about high bed occupancy rates that force contagious, undiagnosed patients into crowded hallways right next to vulnerable people.
The great enemy of the epidemic detective is time, because of incubation periods, right?
Exactly. If a pathogen takes 5 to 7 days to make someone symptomatic, the people showing up at the emergency room today complaining of fever are just the peak of the iceberg. The actual contamination event, the moment the pathogen entered the water supply or the food chain, happened a week ago. By the time the rapid response team forms, defines the cases, and starts looking for the original contaminated sample, that specific batch of food has been eaten or the water has washed down the river.
To really visualize how high the stakes are and how fast these teams have to move, let's look at a real-world investigation. The June 2019 outbreak in Aske, Norway.
A classic case study.
Let's picture the geography. Aske is an island municipality. It has a population of about 29,500 people. It's a contained environment. Out of nowhere, within a tight 24-hour window, 10 people are suddenly hospitalized with severe fever and crippling diarrhea.
10 people in 24 hours.
Simultaneously, 30 more residents rush to local out-of-hours care clinics.
That speed is terrifying, but it's also the vital clue. The local medical officer begins cross-referencing the patient intakes and realizes a pattern. Many of these patients, despite not knowing each other, have home addresses clustered in very specific neighboring geographic zones.
That spatial cluster is the alarm bell.
It immediately pointed the epidemiological sleuths toward a shared communal resource. In an island municipality, a sudden geographically localized spike in gastrointestinal distress almost always points to the drinking water.
That makes total sense.
Through rapid descriptive investigation, mapping the exact addresses against the municipal infrastructure, they traced the source back to a specific node in the water supply network. They called it Reservoir X.
And Reservoir X wasn't some state-of-the-art facility. It was a water supply system originally built in the 1950s, utilizing unlined mountain caverns.
Unlined mountain caverns for municipal drinking water.
Unlined mountain caverns. Because the rock is porous, it is highly susceptible to environmental runoff, especially after heavy rains, which can carry animal feces directly into the drinking supply.
The lab teams rushed samples and quickly identified the pathogen as Campylobacter.
Campylobacter is notorious for causing explosive gastrointestinal illness.
And because the detectives moved so fast, bypassing the days it might normally take to recognize a pattern by immediately connecting the clinical symptoms with the geographic map, they were able to act decisively.
What did they do?
They triggered an immediate municipality-wide boil water advice and physically took Reservoir X offline the very next day. They cut the head off the snake.
It is absolute textbook epidemic detective work. They caught the iceberg. But this entire sequence of events brings up a fundamental philosophical question about how we handle public health.
It does.
Tracking outbreaks after they happen, tracing them back to a mountain cavern while dozens of people are already hospitalized is incredible science. But what if we could stop infected patients from ever walking into the clinic in the first place? What if we could build a system that identifies the iceberg before it even forms?
This specific challenge, the failure of the reactive model, leads us directly to the innovations in the highly critical perspective proposed by Dr. Kadialis Srivatsa. In the comprehensive materials, business plans, and personal accounts we reviewed, Dr. Srivatsa presents a radical reimagining of clinical triage.
Dr. Srivatsa isn't an armchair theorist. He brings over 50 years of frontline clinical experience to the table. And his fundamental argument is that our traditional model of healthcare triage isn't just inefficient, it is actively lethally flawed, and it directly contributes to the spread of antimicrobial resistance and pandemics.
The traditional model relies on human behavior, which is predictably irrational when faced with illness.
Tell me about it.
A patient feels sick, they develop a cough or a fever, their first instinct is often denial. They ignore the symptoms, they go to work, they get on the subway because they don't want bad news or they can't afford a sick day.
Or they just think it's allergies.
Right. Then, when the symptoms become unbearable and critical, they panic and rush to the emergency room or a crowded walk-in clinic.
And what happens on that journey? They infect the bus driver. They infect the receptionist at the clinic. They sit in a waiting room coughing next to a pregnant woman or an elderly man. They infect the nurses, the junior doctors. The very act of seeking traditional medical care becomes a super spreader event.
Dr. Srivatsa is incredibly candid about the personal and philosophical origins of his drive to change this system. In his writings, he emphasizes that his innovations were not born out of a grand, abstract desire to save humanity or win a Nobel Prize.
He's very practical about it.
He roots his methodology deeply in his Hindu belief system. He states that every human must first ask a simple question about their intention before they speak, act, or create.
He looked at his own intentions very honestly. He openly shares that his initial intention in developing his first innovation, the Pediatric Assessment Tool, or PT, was highly pragmatic. He simply wanted to reduce the frequency with which inexperienced junior doctors were waking him up in the middle of the night for non-emergencies.
It started as a way to just get some sleep.
Exactly. He needed a standardized way for them to assess risk.
But that pragmatic intention evolved into a profound moral crisis for him. He details how, by 1999, he made the drastic decision to stop working in hospitals entirely.
That's a huge shift.
He states it became unbearable for him to watch children die due to what he saw as inadequate care and, critically, cross-infection caused by the medical staff themselves. The hospital environment was killing the patients it was supposed to save.
So he transitioned to working as a family physician in the community. And it was there, on the front lines of primary care, that he witnessed the daily, relentless abuse of antibiotics. He saw patients demanding drugs for obvious viral infections and doctors capitulating.
Because it's easier to just write the prescription.
Yeah. Driven by the very real fear of getting infected by his own patients and bringing a lethal pathogen home to his daughter, he created Maya.
Initially, Maya wasn't a complex app. It started as a brilliantly simple concept, a fridge magnet.
A fridge magnet? I love that. So simple.
A color-coded system that allowed families to assess symptoms at home. It helped people understand exactly when they needed to seek help and when it was safe to stay home.
He saw how effective the fridge magnet was at changing behavior, but he also recognized its limitations. A fridge magnet can tell a mother when to take her child to the doctor, but it cannot identify geographical clusters.
Right.
It cannot warn the local health authority that an epidemic is brewing. To solve the macro problem of pandemics and AR, he integrated the logic of Maya with information technology to create the Prima kiosk.
The Prima kiosk represents a shift from individual diagnosis to infection screening at scale. And the engineering constraints he placed on it are fascinating. To reduce global disparities, the technology had to be accessible to everyone, not just the wealthy.
Because if it's only in rich neighborhoods, it doesn't stop a pandemic.
Exactly. While competitors were building elaborate telemedicine booths that cost upwards of 50,000 rupees, Dr. Srivatsa targeted a price point of just 3,000 rupees for the Prima kiosk.
3,000 rupees. It's designed to be ubiquitous. It is multilingual, and crucially, it is illiterate-friendly. It doesn't require the user to read complex medical jargon.
It utilizes a highly simplified 3-symptom input system and intuitive color-coded alerts. If the user inputs a combination of symptoms that suggests a contagious infection, the system generates a blue alert.
The genius of the blue alert is that it acts as an absolute gatekeeper. The primary goal is to keep contagious people out of the hospital ecosystem. If you trigger a blue alert, the kiosk immediately directs you to self-isolate.
It keeps you away from the waiting room.
It might advise you to consult a pharmacist remotely. And simultaneously, it silently alerts local public health officials that a potential infectious cluster is forming in that specific neighborhood before a local epidemic can take hold. The stated business objective is staggering: to reduce unnecessary emergency room visits by 80%.
Imagine the impact of an 80% reduction in ER crowding on hospital-acquired infections.
It would be revolutionary. Now, it is imperative that we impartially report on the intense friction Dr. Srivatsa has encountered in trying to implement this system, as detailed in the source document.
Yes, we need to cover that.
He expresses profound, blistering frustration with the global health establishment.
His perspective on institutional resistance is a core component of his narrative in these documents. Despite the obvious utility of the system, he expected governments to eagerly adopt it.
But they didn't.
Instead, he realized that what he terms the medical mafia, the WHO, and vested interests would not allow his system to flourish.
And again, to be clear, we are reporting the claims made in the source material. We are not endorsing these viewpoints, but conveying his argument.
Right. In his view, A decentralized, empowering triage system threatens their centralized control and revenue streams. He argues that the strategies implemented by the WHO, relying on traditional testing, slow vaccine development, and passive monitoring of antibiotic use, have, in his words, miserably failed.
He is particularly critical of influential figures and non-clinical experts, right?
Yes, specifically naming individuals like Bill Gates or laboratory microbiologists and veterinarians who are driving global health policy despite never having worked day and night in a clinical setting for 30 years, as he has.
He views their top-down, tech-heavy solutions as disconnected from the brutal realities of frontline patient behavior.
To emphasize the sheer gravity of the AMR crisis and why he believes a radical systemic change like PRIMA is required, he draws a fascinating analogy. He compares the looming AMR catastrophe to a video detailing what would happen if oil reserves ran out in Israel.
Oh, wow.
It wouldn't be a gradual decline, it would be a hard, catastrophic stop for the entire community. Everything halts.
He stresses that the public has been lulled into a false sense of security by COVID. People wrongly view AMR like a pandemic wave, something that peaks, causes chaos, and then fades away into a new normal.
He insists AMR is not going away, it's here to stay, and it will continuously, relentlessly undermine modern healthcare.
He warns that by the time the general public realizes that resistance to vital drugs has jumped from 42% to 52%, it will be far too late to reverse the damage.
His ultimate call to action is a fundamental mindset shift. He is demanding that people understand it is no longer safe to mindlessly rush to the hospital, demand an antibiotic from the chemist, and assume they will be cured.
The hospital is dangerous. The antibiotics are failing. The solution is rigorous, technologically assisted prevention.
And from a purely functional standpoint, regardless of the institutional politics, the PRIMA kiosk is a massive leap forward for antimicrobial stewardship. The system doesn't just triage, it educates in real time.
Yeah, if you input viral symptoms, the kiosk tells you plainly, 80% of colds and flu need NO antibiotics.
The business plan outlines a goal to reduce inappropriate patient demand for antibiotics by 30% simply through this point-of-contact education.
AI triage and keeping patients out of the hospital is an incredibly vital piece of the puzzle regarding prevention. But we must address the reality of the patients who are already infected. For the millions who will inevitably contract a multi-drug-resistant escape pathogen this year, prevention is too late.
If our antibiotics are failing and the biochemical pipelines are drying up, what exactly does the arsenal of the future look like?
That brings us to our final exploration, the arsenal of the future. We're being forced to look beyond traditional antibiotics entirely. And surprisingly, one of the most powerful weapons in this fight is an old technology applied in a new way: vaccines.
Vaccines are truly the unsung heroes of the antimicrobial resistance fight. The World Health Organization report notes that better, more comprehensive use of existing vaccines, combined with the development of vaccines against just 23 specific high-priority pathogens, could reduce global antibiotic use by 2.5 billion doses annually.
2.5 billion doses a year that we wouldn't have to swallow. That is a massive reduction in evolutionary pressure. But why exactly are vaccines so much more resilient to resistance than antibiotics? We see viruses like COVID or the flu mutate around vaccines all the time. Why don't bacteria?
It comes down to mechanism and timing. Vaccines are essentially resistance-proof in this context because they work prophylactically.
They prevent it.
They train your body's adaptive immune system to recognize and destroy the pathogen before a full-blown infection can ever take hold. When the bacteria enter your body, they are met by an overwhelming multi-pronged attack from your own antibodies and T cells.
Right.
Because the invading population is wiped out immediately while their numbers are still tiny, they never have the time, the resources, or the massive population size required to mutate and evolve resistance.
Oh, that makes sense.
Antibiotics, on the other hand, are introduced when the bacteria number in the billions, providing a massive casino of genetic mutations for the drug to filter through.
But for those active drug-resistant infections where a vaccine wasn't available, science is pushing the boundaries of non-antibiotic therapies. And my absolute favorite of these, the one that sounds like science fiction, are bacteriophages.
Phage therapy is experiencing a massive renaissance right now.
I love talking about these. Bacteriophages are essentially viruses that evolved specifically to hunt, infect, and kill bacteria. They're like targeted biological snipers.
The evolutionary irony is quite profound. We spent the last century pouring billions of dollars into engineering the perfect synthetic chemical to kill bacteria. And it turns out our most effective weapon might just be the bacteria's own ancient natural predator.
A virus.
A virus that has spent 1 billion years perfecting the exact biochemical mechanism needed to break into a specific bacterial cell, hijack its machinery, and blow it up from the inside.
And unlike a broad-spectrum antibiotic that acts like a carpet bomb, wiping out the good, essential bacteria in your gut along with the infection, a bacteriophage is highly specific. It only targets the specific strain of superbug it was programmed for.
Yes, exactly.
It neutralizes the threat while leaving the rest of your delicate microbiome completely intact.
It is a phenomenal, elegant mechanism. Beyond phages, the sources also detail the increasing use of monoclonal antibodies.
Oh,
Instead of trying to kill the bacteria directly, these lab-engineered antibodies can be infused into the patient to neutralize the specific toxins the bacteria produce, essentially disarming them so the immune system can mop them up.
like cutting the wires on a bomb.
Very much so. We are also seeing incredible advances in nanotechnology-enhanced antimicrobial peptides. These are engineered at the molecular level to physically disrupt bacterial membranes or bust through those impenetrable biofilms we talked about earlier, exposing the dormant bacteria hidden inside to the immune system.
But alongside this futuristic new tech, hospitals are fiercely debating and sometimes fighting over new procedural strategies for antimicrobial stewardship, or AMS. We are seeing strict formulary restrictions now where the most powerful last resort antibiotics are physically locked away.
The doctor cannot just prescribe them.
Right. They require special documented permission from a dedicated AMS team. They are also implementing mandatory 48 to 72-hour antibiotic timeouts.
The timeout is a crucial systemic safeguard. After 2 or 3 days of empirical antibiotic treatment, the attending physician must formally pause the treatment protocol.
Just hit pause.
They must review the newly returned lab cultures, assess the patient's clinical response, and formally justify to the system why they are continuing the antibiotic, or, ideally, step down to a narrower spectrum drug.
But one of the most highly debated, almost aggressive stewardship strategies mentioned in the literature is selective digestive decontamination, or SDD, heavily used in certain European ICUs.
SDD is a fascinating flashpoint in critical care medicine. The concept is preventative. You give a critically ill, mechanically ventilated patient a paste or a liquid containing non-absorbable antibiotics.
So they don't go into the blood.
Drugs that do not enter the bloodstream, but stay entirely inside the gastrointestinal tract and the throat. The goal is to aggressively wipe out potential opportunistic pathogens lurking in the gut and the mouth before they can be accidentally aspirated into the lungs to cause ventilator-associated pneumonia, or before they can migrate through the gut wall into the blood.
And the data shows it works, right? It demonstrably lowers mortality rates in mechanically ventilated patients.
It absolutely lowers pneumonia rates and short-term mortality. But it is incredibly controversial among infectious disease experts. The debate centers entirely on the long-term ecological cost.
Because of the evolutionary pressure.
Yes. You prevent a pneumonia infection today, but what are you doing to that patient's gut microbiome? More importantly, by intentionally flooding the gut with these drugs for weeks, are you creating a massive, localized, selective pressure environment?
You might be saving the patient today, but essentially turning their stomach into a bioreactor.
A breeding ground for new, highly resistant strains, like vancomycin-resistant Enterococcus. The medical community is deeply split on whether the short-term clinical gain is worth the long-term evolutionary risk.
It's the ultimate high-stakes balancing act. How much risk do you accept today to prevent a catastrophe tomorrow? Finally, to help doctors make those exact decisions without flying blind, the entire field of diagnostics is undergoing a revolution. The days of waiting 72 hours for a petri dish to grow a culture are ending.
We are moving toward rapid precision medicine. The frameworks now being deployed utilize machine learning and biochip-simulated genotypes.
Sounds like sci-fi again.
Imagine a tiny chip that takes a blood sample and instantly analyzes the genetic signature of the bacteria present. It doesn't just identify the bug. It reads its DNA to instantly detect if it possesses the gene for an efflux pump or a beta-lactamase enzyme.
That is incredible.
It accurately predicts exactly which drugs the bacteria will be resistant to within minutes, allowing the doctor to prescribe the exact right narrow-spectrum treatment on day one.
Abandoning the shoot first, ask questions later approach that caused this mess in the first place. We have covered an immense amount of ground today. From Alexander Fleming's prophetic ignored warning in 1945 to the complex microscopic machinery of enzymatic degradation and
A
biofilms.
lot of biology today.
A lot. We unpack the socioeconomics of self-medication, the diagnostic paradox of malaria, and how the sheer chaos of the COVID-19 pandemic threw gasoline on the evolutionary fire. We tracked a real-time outbreak in Norway, explored Dr. Srivatsa's radical, deeply personal vision of using AI kiosks to keep infectious patients out of our failing waiting rooms, and marveled at the futuristic potential of bacteriophages and biochips.
And this is the moment where we have to connect all of this vast, complex data directly back to the listener. The statistics, the 39 million projected deaths, the $100 trillion economic costs, they are daunting. They feel abstract,
They really do.
but they are entirely driven by millions of individual localized choices. The next time you have a cold, a viral cough, or a sore throat, remember the 88% of people who do not understand how this biology works.
Remember that an antibiotic cannot cure a virus.
And demanding one is an act of ecological self-sabotage. Your demand for prescription at the doctor's office doesn't just disrupt your own vital gut microbiome. It actively, permanently shapes the evolutionary environment for everyone on Earth. We all share the exact same microbial ecosystem.
Exactly. It's a shared global responsibility. And I want to leave you with a final thought to mull over as you go about your day. We have spent the last 100 years locked in a militaristic arms race, trying to invent stronger, more destructive chemical bombs to drop on the microscopic world. But as we look at the incredible targeted potential of bacteriophages, the absolute necessity of protecting our internal gut microbiomes, and Dr. Srivatsa's vision of AI networks designed to passively prevent transmission rather than aggressively fight an infection, you have to wonder.
It really makes you think.
What if the future of surviving the superbug era isn't about fighting a war at all? What if it's about finally learning how to lay down our chemical weapons and actively negotiate a sustainable peace treaty with the microscopic world? Thank you so much for joining us on this deep dive. Stay curious, stay informed, and we will see you next time.